You know, healthcare delivery begs more questions these days than answers. And I think that we're all in that column of confusion about where we're headed and what the delivery systems are going to look like 5, 10, and even 15 years down the road. Even in the last 15 or 20 years, breakthroughs in technology, training, and even patient satisfaction have changed the landscape and given us a seemingly infinite array of options for treatment. But cost and cost drivers have created constraints that suppress the full potential for patient care. Some are essential, but as we all know, others are artificial impediments that have nothing to do with health care. As a registered nurse for nearly 30 years now, I can attest to the dramatic changes in healthcare delivery as well as the processes that drive that care. Standard practices, say in 1980, are virtually unrecognizable today. The blessing is that we know what we have seen has translated into improved patient care in most cases. The challenge is how public policies and laws keep pace with these new normals in the scope and in the practice of health care. The other tension, as we all know, is cost. When it comes to scope of practice, for example, does the line we draw impact and drive cost unnecessarily? Can we find the balance that maximizes patient safety and controls cost? Over the years, the legislature has been a critical part of this process and often becomes the reluctant diviner. Where do we draw the lines? How do we ensure patient safety without unnecessarily preventing access to qualified providers in a competitive marketplace? These policy questions become complicated, especially when political overtones are infused into debates. In any case, the goal is keeping the main thing, and that is, as an end result, a healthy population. I'm very pleased with our panelists that we have with us today. I want to start by introducing them. We have 3 experts who will bring insight into this discussion. And let me begin by starting to my left is Dr. John McFadden. He is the interim dean of the College of Health Sciences at Barry University. A practicing CRNA, he joined Barry University's Master of Science program in anesthesiology full-time in 2001. Originally from the Philadelphia area, Dr. McFadden holds a Master of Science in Healthcare Administration and a Master of Science in Nurse Anesthesia from St. Joseph University and an MSN from the University of Tennessee and a PhD from Barry University. Dr. McFadden lectures on clinical topics, professional practice, leadership, research, and evidence-based practice. His areas of special interest include bioethics, accreditation, and transition theory. Please give him a warm welcome.
Thank you.
Next, we have Dr. Kenneth Boyle, who is an optometrist practicing with Brevard Vision Care. He graduated with both bachelor and master's degrees from the University of Florida. After working for 3 years in banking and manufacturing, he returned to school for his optometric training. Not sure what that says about banking. He graduated with honors from Southeastern College of Optometry, which is now called Nova Southeastern University of the Health Sciences in Miami. His special area of interest in eye care is diagnosis and management of ocular diseases. Please give him a warm round of applause. And last but not least, is Dr. Christopher Saslow. He is the Associate Chief Nurse for Clinical Practice at West Palm Beach VA Medical Center. Chris finished his MSN from LaSalle University in Philadelphia in 1995 and his DNS from Florida Atlantic University in 2007. He's a past president of the Florida Nurse Practitioner Network and has been recognized by the American Association of Nurse Practitioners, both in 2005 and 2009, in excellence as a clinician and an advocate. He is also an active member in the coalition of the Advanced Practice Nursing Organization. Dr. Saslow, welcome. We're going to start with a series of questions to the panelists. The first one, most likely Dr. Boyle, would be probably best directed at you. Some scope issues have been opposed in the past due to concerns over patient safety. what training given at the educational level would ensure patient safety in your particular field?
Well, thank you, Dr. Grimsley. Can everybody hear me okay? As you heard from my background, it's not the typical background that an optometrist would take, a bachelor's in finance and an MBA, but optometry was really literally a second career. But everybody that goes into optometry school has a 4-year degree, and then it's a 4-year doctorate training after that. The training consists the first 2 years of the same things that are taught in medical school. In fact, at Nova Southeastern, we take the same anatomy, physiology, take the same pharmacology, take the same biochemistry with the same professors, same books, etc., as the osteopathic medical students and the dental students. Then we do 2 years of training specifically in eye disease and systemic disease related to the eye, such as diabetes, multiple sclerosis, irritable bowel syndrome, you name it. If there's a disease system in the body that has an effect on the eye, it's taught in that part of the 2-year curriculum. Then we do clinical rotations, which consist of being either in a clinic run by the university or an outside clinic. Some of the clinical rotations are at VA hospitals, for instance. That's a very common one. Bascom Palmer Eye Institute, the ophthalmology training facility at the University of Miami. So the optometry students are exposed to and are dealing with all treatment and management of all forms of ocular disease. We also have 3 levels of national board certification that we must go through that include all of the pharmacology that there is, includes pharmacology systemically as well as specific to the eye. And we do, even though in Florida we can't do this, there's an injectable medicine that is required to be done. You have to do an injection on a patient to pass the Part 3 of the national board. Florida is one of 3 states that does not have oral prescription capacity, which is kind of odd because there's certain oral medicines, for instance, amoxicillin, that is free at a lot of places, or $2 or $3 copay. Yet we can write all the topical medicines, drops, creams, ointments that are necessary for the eye. That's kind of a subject for down the road. But the last part, I would say, of training, I came out of optometry school 18 years ago, but we have a requirement set forth by the legislature of 30 hours of continuing medical education every 2 years, including 6 that are transcript quality, meaning you have to take a test. And so everybody has to stay current, and I echo what Senator Grimsley said about the changes. It's dramatic, especially from a technology standpoint, what's changed in our profession, and you literally have to be a student your whole life. The training is a good background, but that's really just what it is, the background.
The other 2 of you like to answer that question as well? Have anything to add?
Certainly, I'll jump in, and thank you, Senator Grimsley. And on behalf of the Florida Association of Nurse Anesthetists, it really is my honor to be here. Obviously, in my current role as the interim dean for Barry University's College of Health Sciences, education and patient safety is in the forefront of my mind on a daily basis. I think that education and patient safety are issues that are germane to every profession: physicians, nurse practitioners, therapists, airplane pilots. And we have to keep in mind that we have some very key benchmarks that all educational institutions have to meet. Accreditation, we have pre-licensure examinations, and certainly we have national certifications. But no professional enters a profession as an expert. We all enter as novices. And so it's not just the pre-licensure education that guarantees quality patient safety. It is the lifelong learning and the continuing education. And so I think one of the keys is ensuring that our practitioners have the availability to the experiences to continue to evolve as experts over time. And certainly restricting access to those experiences prevents the ability to become an expert, and that's what diminishes patient safety. So I think that's one of our keys.
Okay.
And if I can just add on to that, I think Dr. McFadden has a really good point about the evolution of healthcare itself. I think that while Florida, I think, still has some opportunities to overcome when it relates to scope of practice and issues that allow healthcare to really absorb what it's going to have to absorb, I think if we look to example in other states that have been very successful and that clearly demonstrate that education evolution of the ongoing process and the ability to let people practice to the scope and complexity that they were trained to do really is going to be critical, especially now given the affordable care issues that we have to face without delay. We don't have any more options. It's no longer a if we can, it's now how we can.
Mm-hmm. Thank you very much. Next question, what evidence exists or what examples can you give that would show that your field's issue will increase access to care at decreased cost, thus benefiting employers and employees alike? You feel free to.
Would you like me to start with that? Because
Okay,
we've actually done a couple of studies. The Florida Optometric Association had some studies to look at a couple of different things. One is the geographic location of optometrists versus other health cares that can treat eye disease, and we're in all 67 counties. Optometrists, as a rule of thumb, tend to be more rural, and there's a larger number. So the access issue is blanketed, whereas if you have competing medical specialty, they're not in all 67 counties, and sometimes it's an hour and a half or 2-hour drive. The second area of that is the relative cost. While it's basically the same cost for a patient who has an eye problem to see an ophthalmologist as it is an optometrist, it's a different cost if they end up in the emergency room. And unfortunately, that's where a lot of them do end up. And the cost to, I know a lot of people out here are in health plans, the cost there is not a couple of times bigger, it's 10 times bigger, 15 times bigger when a patient goes to an ER. Keeping them out of an ER it would be a very big cost savings. And we've actually had a study that was run through for looking at all the Medicaid numbers in the state of Florida. It would save about between $75 and $120 million a year if patients had direct access to the optometrist versus going through the ERs. And the other thing is back to the issue of what the scope of practice does. And I was talking about this a second ago. When, let's say I have a patient that comes in with a bad sty and they need an oral medicine, but I'm in Florida, and we're in one of 3 states where we don't use oral medications, but we use all these topicals and creams. We can put the patient on a topical medicine that costs between $75 and $120, but they could have taken an oral medicine that was either free or $2 or $3 copay. It's kind of crazy. And yet that's a limitation just strictly by scope of practice.
Well, if I could add on to that, I had an issue in my old house district, which is now Chairman Hudson's district, where we had a lady that went into the optometrist on a Friday afternoon. She had herpes in her eye.
Shingles, yeah.
Do you know the case?
I do.
She's, for the rest of the audience, I'll tell you, she went in to see the optometrist. He has a relationship with an ophthalmologist in Fort Myers, and he tried to reach the physician and could not do so. So he said, go on and go to the emergency room and they'll take care of you. Well, and that's where, and someone who's worked in the emergency room for a long time, I'll tell you that I don't know that much about the eyes, and the physicians that I work with, I think Dr. Pigman is here, Representative Pigman is here as well, and he would probably tell you the same thing. We don't always know what those are, and so this lady went and she was told that she had something else and to go home. Well, she went back on Saturday, and by this time, the physician's a little belligerent with her and said, look, don't come back to the emergency room. Well, long story short, she finally got in to see the ophthalmologist on Monday or Tuesday, and the issue with her eye was it wound up having to be sewn shut, and it's permanently shut now. And this was a Medicaid patient, so this was another cost to the state of Florida that could have been handled on that Friday afternoon had that optometrist been able to give her an antiviral to take.
In that antiviral, if the patient doesn't get it within about 72 hours, their chance of success is very poor, and they typically have a tremendous amount of discomfort, what's called post-herpetic neuralgia afterwards, forever.
And she's still suffering some issues from it. I don't know if the other two of you have anything else you want to add in your line of work?
Certainly cost and access are key buzzwords these days, but cost and access really become irrelevant unless we're assured that quality is equivalent across all providers. Mm-hmm. And the good news for us is that the data show that all of our healthcare professionals, nurse practitioners, nurse anesthetists, optometrists, physical therapists, pharmacists, physicians are providing excellent care, not only here in Florida, but throughout the United States. So I think that we can put that argument to rest. I think that one of the things that we really do need to consider whenever we're talking about access is that there is one group of professionals who remain the single largest group of healthcare professionals in the United States, and that is registered nurses. There are more than 3 million registered nurses in the United States. So we can't talk about accessing the healthcare system without including that particular group of healthcare professionals in the conversation. Right here alone in Florida, we have more than 150,000 registered nurses, and a good 10% of those are nurse practitioners, advanced practice nurses, nurse anesthetists, nurse midwives. And so we can certainly affect access by using all providers to the full extent. We also know that increasing access to care certainly drives down the cost of health care overall. The earlier people access the system, the more engaged they are with health promotion and health prevention. In the long term, the more we save in terms of costs of health care. So using nurses and all health care professionals to their full scope of practice is certainly going to help increase that access and decrease the cost.
And I think to add on to that, one of the things that is probably most critical is that we've been demonstrating the sustainability and the efficacy of advanced practice nurses as well as other allied healthcare professionals in the safety and the efficacy of the treatment of our patients. What I consistently find a challenge is that when we seek to practice at our education, the response is that we are not prepared. And yet, I don't see the research that supports that particular claim, but I can give you at least 28 studies, including several that were done right here in Florida, 2 of which were Senate interim reports, 1 of which was done by OPAGA, and not too long ago, a governor's report that clearly demonstrates when you look at data and you look at capabilities, advanced practice clinicians, whether it be nurse practitioners, CRNAs, or optometrists, or any of the other allied health professionals, are PharmDs. This is no longer, I know I've heard it's mentioned several times that it's a physician-led ship. If you think about the whole concept of healthcare, and we talk about the true definition of medical home, when it was first birthed, it really is to provide the most efficient care at the right level for that individual based upon the needs. And so my challenge to that would be that we have so many opportunities to provide care, minimize the burden to our healthcare system at the right level and at the right time without creating that unnecessary burden with duplicate care, with care that isn't necessary. You know, working in the VA system, I guess I've listened to a lot about the electronic health record today, and I've heard a lot about the different challenges with scope of practice, but in VA, we are considered independent practitioners. I have my own panel of patients. I collaborate with a physician when I deem it necessary based upon that patient's complexity. That, to me, is the healthcare model that I embrace because it is a collegial approach. It is based upon making sure that that patient gets the care that they need at the time that they need it. And so I think as we look at the electronic health record, and I'm sure we'll talk about that a little bit more later on, you know, those types of things that we've been using in the VA health system for many years. And I've been working for the VA for nearly 20 years, and I've been using the electronic health record since its inception. I think we have a great opportunity to learn from our colleagues who do things successfully, and we need to seek them out to find out what works and why it works best. So.
Thank you very much. Well, when we talk about the goal of renovating Florida's healthcare delivery system to improve effectiveness and efficiency, I think that we all will agree that when, at first glance, that's very daunting when you take a look at that. It does help to deconstruct the multiple parts of the system and consider the forces that include that healthcare delivery. So the first question along those lines begins by asking the panelists to identify some of the many factors that influence the delivery of healthcare in Florida, besides those you've already mentioned. Is there anything else that we can think of?
I think if I can just touch on that really quickly, the geography that we talked about earlier today and yesterday as well, and how we reach our patient populations and what innovations we really do need to embrace as a healthcare industry. We have to be able to look at things that we may not have thought were effective or efficient before. Senator Negrin mentioned yesterday that he had some real ambivalence about the telehealth realm. And I would challenge something like that with, come and visit us at the VA, where we've been doing telehealth successfully. We've been doing telepsych. We do telederm, which with high-resolution cameras that we send out into the community, we can diagnose and make recommendations. We now have started telesurgery. No, we're not doing your appendectomy via the video conference, but there are methods to be able to minimize that patient having to leave their level of comfort or their ability to get out of their areas, to be able to access the right care at the right time with minimal burden to the industry itself.
Well, and I think if I could add to that, in Chairman Hudson's district for years, they've been using telemedicine with cardiologists, with dermatologists, and it's been working quite effectively. And because it is difficult for those patients to make that drive for an hour and a half to get to those specialists. Dr. McFadden, did you have something you wanted to add?
You know, taking a look at the factors that influence healthcare, you can approach that from many different angles. And I guess my first thoughts are certainly economics drives healthcare. We know that folks that don't have healthcare insurance or are uninsured delay accessing healthcare, and that drives up the cost, certainly. We realize here in Florida that we have the third highest rate of uninsured citizens in the United States. And so just by that mere statistic, we know that we have delays going on in people accessing care. That you can take a look at all kinds of statistics and numbers in terms of how many people are uninsured. That doesn't include those that are uninsured part-time, part of the year. They have work part of the year, but no work the other part of the year, and therefore no insurance. And it doesn't include the underinsured. So we know that lack of health care coverage certainly drives up the cost and influences health care. I think piggybacking off what Dr. Saslow said, geography certainly plays an important part. We have more than 100 counties in the state of Florida that have rural components. And we know that folks in our rural areas certainly tend to access the healthcare system less for a variety of reasons, whether it's because the services and the providers are not available, or whether they lack healthcare coverage, insurance coverage. So geography certainly plays into it as well. And then I think we would be remiss if we didn't consider the diverse population that we serve here. Folks that don't speak English as their primary language tend to access the healthcare system less and delay accessing the system. That certainly drives up care. Having an awareness of cultural and value systems of the patient population we serve and how that influences their adherence to our prescriptions and our treatment plans certainly influences the healthcare system. So I think there are so many factors that we have to consider as we're overhauling the system and trying to figure out what are our strategies for addressing those factors.
And I'll add one little, eye care is obviously a very small part of the entire healthcare budget, but there's one little area of inefficiency that's not only financially inefficient, but for the patient it's inefficient, and for the physician it is as well. And that is we've had this system develop where there's vision plans, and a lot of insurance companies will have these vision riders where the patient ostensibly comes in for an exam, primary care, glasses, contact lenses. Oftentimes, the reason the vision has changed is not a vision issue, it's a medical issue, which means now they need a health exam through a health insurance. And if, as a provider, if I'm not on the health insurance plan, well, they have to now go see someone else. If I am on the health insurance plan, well, they may have to come back another day and duplicate a lot of the same things, because otherwise you can't get paid by both. So that system, and our national association has worked to try to incorporate that, get rid of that vision care model essentially and bring it into the healthcare model as a part of primary healthcare, is an eye exam. And it's a medical eye exam, not one for glasses or contacts, because the line is very gray. Cataracts, macular degeneration. In this state, these kind of problems are so prevalent that the majority of people who think they have a vision problem have a medical problem.
And if I can just add one other thing onto that, and that is that we talk about the fact that Florida has literally 2 states. And I think part of our challenge as a state actually is because of the fact that we've created such a burden on scope of practice issues over the years that we've actually nurtured those 2 states to stay as they are. Because if you don't allow the individuals who are allied health professionals or nurse practitioners, PAs, to be able to practice to the full extent of their scope, how can you expect them to be able to geographically move into areas if they're tethered to a physician who sits along the coastline? And I don't say that with any derogatory sense, other than the fact that we can't expect people to move west or east, depending on which side of the coast you're on, into those underserved communities if they can't practice the way we need them to practice. So we're perpetuating that consistent burden.
Well, talk to me a little bit about the VA. You mentioned earlier, you made reference to the physicians that you work with as your colleagues. I know in the civilian world, the advanced practice nurses operate under protocols. In the VA, is it the same way, or is the physician still the captain of the ship like we were taught in nursing school, or is it different?
Well, when we were taught in nursing school, because we're nurses for about the same period of time, we still gave up our chairs when the doctor walked into the nurses' station. We don't do that anymore. We share, we don't give up. But I can tell you that the captain of the ship really isn't the physician, it isn't the nurse, it's the patient. And that is what we need to really rethink and retool the way we focus our healthcare. It isn't clinician-centered healthcare, it's patient-centered healthcare. And as long as we keep focusing on everybody's chess pieces, we're never going to get the patient all the care that they need. So no, in the VA, we don't have the types of barriers that you may have in the community. And what's even more critical to think about is if I'm a nurse practitioner working in the VA and I have my own panel of patients, my physician colleague has his or her own panel of patients, and if I need to see that collaborating physician, I knock on their door, or if I find that they're beyond my complexity, I ask to have that patient reassigned. I'm educated enough to be able to know when I shouldn't be treating somebody. There's always going to be opportunities and risk when you open up your practice to complexity. However, in the VA, it's become a norm. In fact, this year alone, in March of this year, VHA actually drafted their latest handbook on advanced practice, or their section on advanced practice, citing that ARNPs are to be considered independent practitioners, and the only limitation or restriction that can be governed by state statute, in other words, we don't have to pay attention to state statute, is in the role of controlled substances. And that's because they recognize that there are still 2 states in the entire U.S. that don't allow ARNPs to prescribe controlled substances, and it's Florida and Alabama. Quite frankly, I do not want to be the last state standing. However, if I go as an ARNP in my practice and I get called to active duty, everything that is restricted to me as an ARNP in the VA now becomes negated because I have absolute autonomy and full scope as an ARNP in the military. My colleagues who go for a year or who are deployed for a year do everything that they need to do to care for the patients and our servicemen and women at the time that they need that care. They come back to the state, and based upon statutes for that state, they now have to fall back under that restrictive piece. So we still have some challenges, but I feel when I compare myself to my colleagues in the community, and I also work in the free clinic in the community, and I can tell you it's even more restrictive. But a collaborative agreement isn't necessarily required, but clinical privileges are. And so an ARNP has clinical privileges that are assigned by your collaborating physician, not supervising, but collaborating. And that's the person who helps you when you feel as though you have a problem.
Okay. We've all seen a renewed focus on health promotion and prevention. Based on numerous studies, these activities not only decrease the need for tertiary services, but they also decrease healthcare expenditures. How might the current Florida healthcare workforce expand the types of health promotion and prevention strategies currently being offered to our citizens?
Well, I'll jump in if you don't mind. You know, when we take a look at our history and we go back even into the 1800s, it was nurses that began community health and began recognizing the importance of promoting health and prevention strategies. Heck, Lillian Wald, if I remember correctly, was our first community nurse in New York and began these types of programs. So this is an inherent part of what a nurse does, is health promotion and health prevention. We also recognize that the strategies have to be specific to the population we're serving. Those strategies that work for our elderly population will not necessarily work for our teen population. And so we have to be cognizant of that. I think that when we take a look at health prevention and health promotion, we know that if we can increase these strategies, we certainly will decrease costs over time and have a healthier population and a healthier workforce. That's important to every business owner. It's important to society as a whole. And when we think about where we deliver care and where we deliver these health promotion and prevention strategies, we have to think outside the box. You know, how many of us are old enough to remember the school nurse? Well, over the past few decades, we've begun to decrease funding for that school nurse. I'm suggesting that maybe we need to rethink that. Maybe we do need to have a nurse practitioner in every school. Maybe we need to take a look at providing prevention and promotion strategies in our community centers, in our pharmacies, in our fire departments, in our churches. We know that that's going to help bring people along, and in the long run will help us in terms of decreasing costs and increasing access.
Well, being as optometry is the primary eye health care profession, it's actually right up the alley of optometry. And unfortunately for all of us, there are a number of different eye problems that have no symptoms or symptoms you wouldn't associate with the condition. Two big areas. One is pediatrics. A 5-year-old, 6-year-old kid who's struggling with reading may have an eye tracking problem, may have a focusing problem. So there's things there that as a parent you wouldn't necessarily know, but through an eye exam you will detect it, and that will have a tremendous impact on that kid's education, ultimate productivity for society. The second area would be more towards the aged. A lot of eye diseases are very asymptomatic in the early stages, and one of the analogies I use with my patients is I could have glaucoma, I could be almost blind from it, I wouldn't know if I didn't have a periodic eye exam. You have to literally lose 95% of your optic nerve, which takes the signal from your eye to your brain, before you have a symptom, and sometimes even more than that. It's a very silent disease. Likewise, one of the big problems in Florida is macular degeneration. I'm sure everybody knows somebody with it. And one of the major contributing risk factors to it is smoking. So as part of our education with virtually every patient that comes through, and I do this from probably age 10 or 15 on, is don't smoke and smoking cessation. That becomes a part of a bigger picture, I think, for the patients as well. So in that area, we can contribute tremendously.
And I think from a VA perspective, as well as an advanced practice perspective, VA has actually embraced the whole concept of disease prevention and health promotion for years. Right now, in a VA health record, we have more than 125 clinical reminders that will automatically populate based upon a patient's diagnosis or part of their problem list. So somebody who's a diabetic, automatically when I come into the room to see a patient who's got a diagnosis of diabetes, it's automatically going to remind me if I haven't ordered an HbA1c in the last 4 months, or if I have, what that result might be. I'm going to have to make sure that their hypertension is under control, if they're a heart failure patient, making sure that all of the labs are necessary. So those types of preventative measures are a second nature to us, but in the community, as John said earlier, nurses are birthed out of the public health concepts. In fact, nurse practitioners, our founder or co-founder, who by the way is still alive today and lives in Florida, and who's mortified on a daily basis at where we stand, actually started in that rural community health concept of prevention and promotion. And I think if we continue to embrace these two avenues, we're going to see the ability to affect some of these healthcare costs a lot more efficiently, especially as we're all allowed to do what we should be able to do right up front without having to duplicate care.
And I'd like to throw in one more thing, and this has kind of come out as a result of the new regulations for electronic health records, which our practice has had them for 14 years, but we had to go to the upgraded version. One of the a couple of requirements on there that are not strictly eye care, but are very much public health. One is checking blood pressure on everybody, and it is scary the number of people that are hypertensive and out of control. And then there's also medication interaction checks on these systems, which allow you to alert somebody that you're taking things that shouldn't be taken because of the interactions. And there's also communication, and diabetics are another one of those where the diabetic changes inside the eyes happen long before patients have visible symptoms, and that gives you also an indication of what their overall control is about. And as part of the protocol, we're always communicating with the physician or nurse practitioner in charge of the diabetic's overall care. This is the status of the eyes right now. It gives them a better idea because oftentimes that's the first organ system that's affected. So you now know where the patient is, even though they tell you one thing and you look at your labs, you get one piece of information. When you find something different, then it may make you go, wait a minute, maybe we aren't as controlled as we thought we were.
And let's talk about coordination of care along those lines, because when you have all these different providers at the table, we know that the care needs to be coordinated, and when it's not, that care results in uncostly emergency room visits and, in the end, just poor outcomes. So the question is, how do we begin to implement those practices that are known to improve coordination of care and, in turn, improve those outcomes? And you mentioned electronic health records, and I wonder if we are seeing, in your experience over the years, have you seen electronic health records helping any with that?
I would say not until this point, and I think it's starting to take off now because there's been such a resistance to embracing electronic health records, and none of them speak to each other by and large. Now, once they start to, and that's going to be a painful process, but quite honestly, it's a necessary process. Once they do talk to each other, you will have a tremendous amount of coordination, and you'll also eliminate a lot of duplication and I see this all the time where my cardiologist told me to stop taking this medicine that my family practitioner put me on because it's going to kill me, and there was never coordination between the two about what was going on. And the number of deaths in this country every year from medication errors is something like 70,000, and a lot of it's avoidable. And the electronic health records would take care of that, along with hopefully helping to get the patient to the right person. But that is a very, very difficult question. And I'm sure everybody in here probably has been to, you need to see this specialist, now you see that specialist, now you see that specialist, now you've made your circle back to the beginning. Unless you get all the practitioners together talking, I don't know that you ever break that system down and improve it.
And what I've seen in the absence of electronic health records is the unwillingness of those specialists to speak to each other, which I find just amazing still.
Well, one more thing I just want to throw in, the medication thing is huge because the majority of patients, even 30 and up, don't know what medicine they're on. And when they get to be 70 and they're on 8, 10, 20 medicines, they're absolutely lost unless they bring a list in, which is 10% of them. So most people don't even know what medicines they're taking. And if you're relying on written records that don't communicate, you're always at a loss.
And then there's the duplication of medical tests. You know, you have someone who's in Colorado that has a broken leg, but then comes to Florida, and we don't have access to those records, so we are repeating the test, and that's more cost to the private sector as well as to the public sector. Well, let's talk a little bit about education of our healthcare professionals. You know, it's evolved over the last few decades. Physician specialties have evolved. Nurses are seeking doctoral degrees and becoming experts in their specialties, and many allied health practitioners, from optometrists to pharmacists to audiologists to physical therapists, have extensive education, often at the doctoral level. Are we using all the healthcare practitioners to their full potential? And if not, what are your suggestions going forward, particularly to the legislative body, of what we can do to assist with that?
Well, if you don't mind, I'll jump in. I think the answer, as we've clearly elucidated over the past 2 days, is no. We're not using our healthcare professionals to their full extent, and we need to begin doing so. I think there are several things that our policymakers can help in moving that train forward. And certainly one is taking a look at some of the restrictions to scope of practice, looking at other states in the country and their models that have been successful in saying we're going to mirror their success story. Certainly, we're not seeing bad outcomes in those states, and so I don't believe that we're going to all of a sudden magically begin seeing negative effects of a loosening of the restriction of trade or restriction of scope of practice here in Florida. I did want to bring up one point, though. This is not a competition between providers. In other words, it's not an either-or where the gain of one provider automatically means the loss by another provider. Really, this is, to me, about both and. This is about both physicians and non-physician professionals working together, again, to increase access and improve the care of our patients. So I think we need to begin changing our understanding, our paradigm, our philosophy, that it's not a zero-sum game. It's really the patient that is the person that's supposed to be in the forefront of our mind. So if we can take a look at it from a policy perspective, I think from an economic perspective, our payers need to make sure that all of our professionals, our healthcare professionals, are reimbursed appropriately for the care they provide. Currently, that does not happen. And I also believe that we need to take a look and expect and mandate that there is interdisciplinary or transdisciplinary collaboration and communication. We know that that improves coordination of care. We know that it decreases medical errors. So we still have some work to do, but it's certainly ours for the taking right now.
And I've often wondered, because we're all required to do some type of continuing education to renew our license, if we shouldn't require some patient satisfaction CEUs. Because even outside the scope, if you just get into the hospital or into the medical environment, you still see turf battles between doctors and nurses or between lab techs and nurses over what their turf is. For example, just this week, I had a physician come to me and complain about the OR director wouldn't let him wear scrubs out of the OR, which he's been doing for 20 years. And he thinks he's doing a good thing for the hospital because he's going out with our name on it, advertising to the community. But she sees it from a completely different manner, and so she called him down in the hall in front of a patient, and when he's quite irate about it. And I think as practitioners, we oftentimes lose focus that it doesn't really matter where he wears his scrubs. What matters is the patient laying on the stretcher. And I don't know if by doing it through a continuing education or having all the employers do it, just as an awareness, that we refocus on why are we really here.
Well, you bring out a good point. Saving a life is not a competition.
Yeah. Yeah.
And we have an issue to echo that where the majority of ophthalmologists want to do surgery. And we compete with them only on the non-surgical cases, but we certainly augment them in not sending them patients that don't need surgery. And most of the time they are too busy and you have to wait quite a while to get in to see them anyway. So it makes a lot more sense for us to do the primary and secondary care. Let them handle the surgical cases. That's what they want to do. That's what they're trained for, and it makes perfect sense. But back to your question about what can the legislature do, I think that one of the hindrances, and I kind of touched on it a little bit earlier, and I think this is by and large our fault as an associated profession, is we haven't educated the third-party payers on the value of our services for primary and secondary care, and we've been excluded from a lot of the insurance panels, and we need access to the insurance panels. It's really more our patients need access to us through the health insurance they already have. Part of that may come about through this part of the Affordable Care Act that somewhat breaks down the vision versus health insurance issue, but beyond that, the optometrists need to be on the panels, and you can't exactly mandate that. It's somewhat of a business decision, but it certainly needs to be open access for optometrists to get on panels of health providers.
Everyone needs a seat at the table. Yeah.
And I think what you just said is probably key, because it's not just about I want to be impaneled, it's I want to be available for access. And it really isn't about just being impaneled on an insurance company. It's about making yourself available to the population that may not otherwise have that availability because we're restricted by scope of practice here in the state, or there's legislation that prevents us from being able to obtain that position on an insurance panel.
Let me do one final question real quick. Let's talk about research. Research from around the states, and then some would argue around the country, continues to support the use of allied healthcare professionals to work in tandem with others to maximize resource dollars. Opponents argue that education is insufficient to support the expansion of scopes of practice in Florida. What types of research has been done that would argue favorably in the expansion of scope of practices for allied healthcare professionals that you're aware of?
Well, I need to ask one question first, and I'd like to know what research has been done that shows it isn't favorable. We have multiple studies out there, and I mentioned earlier the OPAGA, the Senate Interim Report, the Tax Watch, the Governor's Report, and those are just in Florida, and yet we have a myriad of studies. In fact, we have one researcher that did a meta-analysis of the safety and efficacy of practicing within your education and training, and out of that meta-analysis, it was very clear that there is no reason why we should not allow advanced practice nurses, PAs, other allied health professionals to be able to practice to the way their education has been provided them. The other piece to that is that when you look at research itself, we need to be able to take the research and truly give it the value that it possesses. If you are going to spend the money and spend the time to do an analysis of efficacy, safety, and plausibility, would you not then want to take that to the next level? It would be like somebody coming up with the magic bullet for cancer and saying, really good job, but we're just not going to use it. I feel like sometimes we shoot ourselves in the foot. You know, if you're going to ask for the information, put it to use. Don't just say thank you very much and we'll get back to you on that. Take the next step. If we're looking at a challenge in the next year that is going to put us on our own fiscal cliff, then don't you think that we need to look at all of the available research that's already been provided to our legislators on numerous occasions and say, help us define the best way possible to be able to make sure that we're providing the care that's available to you now and in a timely fashion?
And we've had in eye care, we've had a number of studies, and when we brought them to the legislature, the response back from the opposition was, well, Florida's different. Well, and it's also one of those things where you can't compare what's happened in Florida with the safety of something that isn't there. In other words, you know, there's not been an enhancement in the scope of practice for optometry, so you can't compare that safety in Florida. But you can't take what's outside of Florida because it's different in Florida. So we've fought that battle, but there's a real simple acid test that we would just ask, and a lot of you in the insurance industry are maybe aware of this, but look at malpractice rates across the country. Optometrists in Florida have been using topical medicine since 1986. Most states have been using oral medicines and topicals since between 86 and 90. The malpractice rates are, I say this quietly, but they're obscenely low, and they haven't changed. And there are a handful of states. Oklahoma has been doing lasers for 10 years. Optometrists do advanced practice stuff across the country, and if there is a problem, it's going to come before the courts. And insurance malpractice rates are going to go through the roof. I think everybody understands that, and it hasn't happened. Why? Well, optometrists are conservative, number one, and number two, they're practicing to their level of training, and if they can't do it, somebody else is going to do it. They're going to move it on to somebody else.
I think also educational pathways evolve over time. Certainly the way we educate a healthcare professional today is very different than it was 50 years ago. 50 years ago, only physicians were trained to put IVs in. Only physicians were permitted to engage in cardiopulmonary resuscitation activities. We realize now that that is very different. Time has changed and life has evolved. I think that we have some very strong, very good educational pathways. Frequently our faculty members cross between schools and colleges. So a faculty member who teaches biochemistry in the medical school also may come over and teach biochemistry in the nursing school or in an allied health program. And so I would question the validity of saying that our educational programs are creating risk for patient safety.
And if I could just add on to that, one of the things that I find very important to know is that when we hear about the education being very different. In a number of our universities, our medical students are taking the same coursework as our nurse practitioner students at the same time. Our pharmacology courses, you're seeing med students as well as nurse practitioner students taking that same course with the same didactic, with the same expectations as their colleagues who are going on to the physician path. I think that we've identified, as John just mentioned, in 1958, only a physician was considered educated enough to be able to take a blood pressure. We know now that there are many more things that have the complexity that we would prefer to have our physician colleagues be able to spend the time doing. Start delegating and start allowing your colleagues in the health profession to do what they can do and minimize the amount of time and demand that our limited numbers of physicians have, and moving forward, how our dwindling numbers of physicians will have. So we need to maximize our resources, and if we don't start maximizing our resources, knowing what we know, and by the way, in none of the states that have increased the scope of practice, including prescriptive authority, not one state out of any of the states that have increased it have ever repealed it. So that's got to say something for the validity of what we allow others to do.
Well, thank you. And with that, ladies and gentlemen, we've come to the end of our allotted time, and we recognize that it's only us standing in between you and lunch. I want to thank the panel participants for being here today, and I think the old saying, blessed are the balanced, may be taken away from today's discussion. Unto themselves, we all recognize the importance of both patient safety and patient access. The challenge then is finding quantifiable ways to define how these values make their way into the state's healthcare policies. Over the years, healthcare delivery has benefited from a free market. Competition has invited innovation. Innovation has brought technology and better protocols for patient care. Legislators especially have to devote themselves to understanding the facts and responding with policies that are divorced from the rhetoric. A first step is bringing all sides to the table and making patient-centered care a unified goal of allied healthcare professionals. I'd like to thank the panelists again, and ladies and gentlemen, thank you for participating today.